Shall we go on to our next speaker, Dr. Ashok? Nanda, are you there? He's a senior cataract and refractive surgeon, founder and medical director of Vision Eye Hospital, Orissa, and he would be showing his excellent video. On to you, doctor.
I'd like Sunil to play the video because the internet is not good here also.
And Dr. Ashok Nanda is another very amazing surgeon, very versatile and prolific, and I'm sure he's going to show us something very brilliant.
I'm going to show some of the mistakes I did in a case which I shouldn't have done. This is a 90-year-old person with a grade 4 brown cataract, one-eyed.
Yeah.
So the first thing is, we should not have chosen this patient to be done on a topical because you can land up anywhere. This patient also had some amount of lax geniole. Somehow I could manage to do a rhexis without too much of pull on the genules. So then, second mistake I did was in a brown cataract when the genules appeared to be loose, my hydro was not adequate. I did not try to rotate thinking the genules might become further loose. So I started doing phaco, and you can see when I was trying to hold, the whole bag was getting pulled. So here I decided that to stabilize the bag, at the outset, I would put in a CTR ring and probably go ahead and do the surgery. And once the CTR was in place, I was a little more confident and started doing a direct chop technique. Again, I normally would do a stop and chop in a very hard brown cataract because that gives me more space to manipulate. And in a patient where the genules were loose, doing a stop and chop would have been a little better in spite of having to use a little more energy. So here you can see that I was struggling to separate the posterior plate because I had not had enough space and I was afraid to pull the pieces too much laterally to exert more tense stress on the genules. So in that process, I had to rotate and make sure that the plate was divided properly before taking out the first piece, which I intended to. I had to use two instruments to rotate because my hydro separation was not adequate. So once that was done, then I could manage to remove a piece of endonucleus, which gave me space to manipulate further. This was being done repeatedly. You can see the size of the pupil is coming down. Somehow, once the crack was complete, I could then remove the second half more into the pupillary plane and continue to do the phaco in a more superficial plane. Again, when the genules are loose and you have already put a CTR, taking out the cortex was a challenge. So you must try to hold and sort of swing it laterally rather than pulling it centrally to loosen the cortical fibers. Instead of centripetal force, it should be more lateral and gradual and slow so that it is loosened and the genules are not further stretched. And of course, at the end, I could, with luck, manage to fit in a lens in the bag. But the video was given to actually highlight the mistakes which a person should not do. Never attempt a hard cataract, one-eyed patient, yes, 90 years with a loose genules,
Yes.
without block, that was a mistake.
Yeah.
And
Should have-
do a hydrodissection properly before you
Or you could
actually.
have done a subtenon and you could have given a proper stop and chop and completed the case much faster and got out.
Actually, this patient was referred to me on the table because some other doctor who had taken it for himself did not find it, confident enough to do so. On the table, I did not have any option, but decided to do it.
Now I wanted to ask you directly, do you feel doing a bimanual rotation in a case of a zonular weakness is a safe step to do? I have never done it, so I was asking you.
It is definitely, because if you do one instrument technique, then you're stretching the opposite zonules.
Yes.
So doing it under viscoelastic, and here, remember I told that I did not do a good hydrodissection because of the fear that,
I think one very important message is, in a case of a zonular weakness, doing a hydro procedure appropriately is most important, because only if the nucleus is free can the manipulations which we do further will not impact the remaining zonular.
Less traumatic.
Less
you have
traumatic.
to be less traumatic.
Yeah.
Yes.
Anaga, you ask your question.
Another thing, when the people started coming down, maybe you could have waited, put in Phenocaine plus or this thing, and then continued, because visibility is most important. Already there were challenges of zonular weakness and hard brown cataract. Plus, if the visibility comes down, then there are greater chances of you touching the pupillary margin, then further pupillary,
Yes, that is why I started lifting the pieces into the pupillary plane. I started doing the last in a couple of pieces.
But the intracameral Mydriatics would have made it a little easier.
I know. Yes, that's correct.
Yes. I think it's a very self-explanatory video, unless my expert panel have extra point to add. Shall we go on to our next speaker?